Okay, hi, this is Elliot Fishman, and welcome to Facebook Live. I appreciate everybody being here. I know it's a little bit confusing because now it's Tuesday, it's 1 o'clock, and normally it's Thursday at 12 o'clock, but Thursday is Thanksgiving, and I did not want to interrupt anybody from eating turkey. So that's why we're here now. And I thought I would speak to you about pancreatic cancer. I was trying to think, what should I speak about today, pancreatic cancer or RSNA 2021? And we'll talk about RSNA next week. I know some of you are going. This is actually the first RSNA I'm not going. Get my coffee here in all my years. Obviously, last year nobody went because it wasn't in person. I know they're going to have a small attendance this year, but hopefully everyone will be safe, and hopefully in 2022 we'll be back to a real meeting. But we don't want to jinx ourselves, so hopefully that'll come soon enough. Now, I did want to talk about pancreatic cancer. This is Pancreatic Cancer Month. I should be wearing purple. I was wearing purple the other day on Pancreatic Cancer Day, which was last Thursday, I believe. But I thought I would speak to you about where we are in terms of pancreatic cancer, what things we're learning, and why we think we're making progress. And I've been just summarizing some of the stuff in part because, we've been supported at Hopkins by the Lustgarten Foundation for the past 5 years very generously. And we're doing our annual presentation. We do many reports during the year, but this is the presentation to the board and to their scientific advisors. So we try to show what we've done, what we've accomplished, and where we think we're going. So I think it's very exciting. Now, some of the things to recognize. There have been a number of articles published by many different sites, ranging from the People in Japan Cancer Center to people from Australia to in the US, multiple sites, making the point that pancreatic cancer is present and in theory is detectable anywhere from 6 months to 3 or 4 years before you make the diagnosis. Now remember, with pancreatic cancer, we typically would say you're normal today, you're abnormal tomorrow. And so where does surveillance or any of that stuff come in? But if you say there's a period of time between the diagnosis and the symptoms or signs that would suggest pancreatic cancer, then that gives us a lot of opportunity to be able to really intervene. So I think that becomes very important. There was some work from Japan. They found 3 features. Actually, it was published a few months ago online, but it's in this month's, so it must be December AJR because it came just yesterday. And it makes the point that they talk about 3 signs. One is a dilated duct, abruptly cut off. That one we all knew for a long time. One is what they would call abnormal enhancement, that there's an area of increased enhancement in the gland, which is something we don't typically speak about. And you have this increased enhancement before you end up with the decreased enhancement when you have the obvious tumor. And then they talked about shape changes. We all know that the shape of the pancreatic gland changes in the sense you have a dilated pancreatic duct or you have a mass, and there's atrophy of a distal gland. But what they're talking about, not so much as, but that's kind of late. They're talking about more the shape changes, the lobulations change, that there is some atrophy, but it's more subtle. It's not that atrophy we typically think about downstream from the tumor. Remember, the tumor's here, and downstream there's atrophy. This was more atrophy or subtle atrophy as the first sign of a tumor. So there's a lot of work being done in that area, and there have been several articles with similar but different findings. People have also looked at muscle mass. There's also a lot of work about diabetes, that patients who become diabetic in their 50s or 60s for no good reason, that may be the first sign of pancreatic cancer. And we've always seen that, right? That patient had pancreatic cancer, then you get a history, patient became diabetic 3 years ago. So there's a lot of stuff in that regard as well. So the history part's critical, the imaging part's critical. Now, we also talk about the fact that 30% of pancreatic tumors are missed at the first time they're possibly detectable on CT, because you may not be looking for pancreatic cancer precisely and the findings are subtle. Hence the Felix Project. ability to detect early pancreatic cancer. We've done work with radiomics and deep learning. It seems that our deep learning, we're in the process of doing some outside data to really see how well we really are, is in the 95% range for tumors even under 2 centimeters. So the question is, if we have AI in place, can AI detect the presence of pancreatic cancer when you would miss it because you're really not looking for it? So the thought would be is if you had AI and it worked really well, and it was very good on the true positives, and did not have many false positives, or did not have too many false positives, it could be used for screening that every CT, let's say on a patient over age 40, the computer would look for the presence of pancreatic cancer and perhaps find it. So that's something was our theory, and I think that will indeed work out. We're also working with a company from out west, that's all I could tell you, and we're getting our final contract in place, and I'm just extremely excited about it, where they're very good at handling large amounts of data, not just imaging, but clinical data, lab values, you name it. And then based on all of that data, creating models that are predictable. And in fact, we always talk about the problem with AI in medicine is a black box solution. They have developed a new programming way of a glass box solution. So you can see exactly what made the decision by the computer, and then you could change some of the parameters and see what if you run these 4 parameters, what will be the prediction be? And we've been using that, looking at some old data, looking at pancreatic cystic lesions predicting benign versus malignant. There was an article that was published about 3 years ago that made the point that computer algorithms were better than surgeons or GI docs, but they still weren't great. Well, we're at least 50% better with this new algorithm. Now, maybe that doesn't surprise you because, computers 4 years ago aren't computers today, and algorithms are constantly being developed and improved. And so that indeed is the case. But it's very exciting because now think about what if we can pick up the presence of a tumor and then define specifically what that tumor is. That's what people want, right? If I see a cystic lesion as a benign or malignant, do I need to follow it? Do I need to take it out? Is it aggressive? Is there dysplasia present? Is there a high-grade dysplasia? Or is this just going to be one of those lesions that have no clinical importance and you need to follow for the next 10 years? The recommendation for incidental pancreatic cysts is 9 or 10 years of follow-up. That's a lot of money, that's a lot of stress on patients, that's a lot of grief. And there's an article published by the Early Pancreatic Cancer Detection Group, the CAPS group. Mimi Canto is the key person from Hopkins, Mike Coggins, really terrific work over the 20 years. But they showed that, disappointingly, that even when they screened patients carefully, half the patients who developed cancer developed it in between screening. That even though they were screening, it didn't really help on the outcome because the cancers happened in between the screening. So whatever we're doing, we're not doing it early enough. And their article says we need better techniques or better strategy. So I'm not going to argue with them. I'm going to agree with them 100%. I think we're working on that better strategy. I think AI needs to be developed. Detection and classification. We need earlier detection. We can't have a normal scan, normal EUS, normal CT, normal MR, whatever, and then 6 months later you have cancer. That cancer was there 6 months ago. We know that. We're going to find it. And we're going to find it now. And then we're going to tell you when we find these lesions, is it important? Do you need to take it out? Do you need to biopsy it? Do you need to follow it? Do you need to do nothing? 97% of all cystic pancreatic lesions never get malignancy, but you treat all of them the same until you have a malignancy. That's a problem. We want to know who do we need to follow. Bert Vogelstein, Ken Kinsler, and the group on oncology is working on sampling. Anne-Marie Lennon, working on sampling of the fluid, and from the fluid determine whether or not it's someone that needs to be followed or someone who can just be discharged and never seen again. That'll be great, but then you need EUS. That's expensive, complications. You can't just do 1 million EUSs, right? So our goal is to do non-invasive EUS, non-invasive imaging. We need to use lab values and imaging criteria to look and predict. And that's really what we're working on. So I think it's very, very exciting. And hopefully we sign a contract, we'll be able to tell you precisely who we're working with and how we're doing it. I think it's very, very exciting. And, the Lustgarten project is for the common good, right? So Lustgarten is a foundation. Lustgarten was the head of Madison Square Garden who died of pancreatic cancer, and the foundation was formed in his honor. And all of the money they raise by some wealthy people donating money and people doing marches and people buying sweatshirts, many of you in the audience contribute, that all goes to research. So they're just, it's a research, and what they want to do is they want to find tools that'll improve everyone's life and do early detection. And if it makes money, they'll take that money and give it out in more grants, because Lord knows, detection of pancreatic cancer is one thing, but then we need therapies. We've been working on vaccines for years. We've been working on new chemotherapies for years. Things have gotten better, but things are not great. We're still talking about a 7 to 8% 5-year survival in the big picture of things. That's horrendous, right? It hasn't changed much. So I think we're very excited about the work we're doing, and hopefully we'll keep doing it. Now let's see if there are any comments. John Biacchino, John's home again. I think whenever I speak, John is home. It must be some karma or something. John just wants to be able to not be interrupted when I'm speaking. John is from Staten Island. Many of you know that. And I sent him a song. I can't post it on CTisus. Had a few curse words. But if you want to watch it, go to YouTube or something, and you can see it. It was from last Saturday night on SNL. It was something about Staten Island. It was pretty humorous. I forgot the exact. It was pretty humorous, is all I could say. And Staten Island. There's Manhattan, there's Brooklyn, there's Queens, Long Island, the Bronx. But Staten Island's like a stepchild. It's on the other side of the Verrazano Bridge. Its main job is to hold the Verrazano Bridge when you leave New York and you want to go to Baltimore. So you go through the Verrazano, you go through Staten Island, get on the Jersey Turnpike, and then you head straight home, Delaware Memorial Bridge, Baltimore Beltway. So Staten Island is more than simply holding up half of the Verrazano Bridge and half of the, what's that other one? Not Throgs Neck. Throgs Neck is going to the Bronx. There's some other bridge, I don't know, that goes from Jersey to Staten Island. But John has survived Staten Island and Brooklyn, and from Brooklyn he survived to come to Baltimore. So John's one of our great techs. Anyway, hope everybody is having a great day, and I want to wish everybody from the bottom of my heart a happy and healthy Thanksgiving. And just be careful. Again, COVID is still there. You have relatives, you have friends. Just use some common sense. Hopefully everybody has gotten or is getting their third vaccine. Hopefully you have kids who are over 5. They've been vaccinated. 5 to 11 is doable now. Obviously 11 or above has been doable for months and months and months. And hopefully by President's Weekend, the under 5s will be able to be vaccinated. So that's the next step. But anyway, I hope you have a great day. And if you have any questions, please let me know. And John, happy Thanksgiving to you as well. Okay, guys, have a great day.